So we'll be discussing about Hodgkin lymphoma, current management. We can identify a few important personalities in the photographs, a very characteristic picture of the Hodgkin lymphoma as given in the literature, and the also famous Reed-Sternal cells. This is a brief overview of the class today. We'll be discussing under the following heads: history, clinical feature, diagnosis, staging, treatment, some special situation, followed in the end by a small quiz. So let's begin. So the history of Hodgkin lymphoma dates back to almost 17th century, when first paper on this was described. Then modern science begins with Thomas Hodgkin's paper in 1832. There have been multiple, enhancements or what should I say, advisories during the course of history. Like first combination chemotherapy was given in 1960s. In the 1964-65, also important 4 types of classical Hodgkin lymphoma were described as by Lukes and Butler in the Rice classification. Then the gold standard ABVD, which remains the gold standard even today, was given in a randomized trial from that time versus MOP chemotherapy in 1973. In 1994, the real classification came, which introduced us to NLPHL, the other type of Hodgkin lymphoma seen in 5% of the cases. Anabastatin came in 1971. Monoclonal antibodies were introduced into the Hodgkin lymphoma management in around 2003. And somewhere around 2015-16, we had introduction of checkpoint inhibitors. Lastly, around 2019, we had introduction of CAR-Ts and new monoclonal antibody, CAPI. So classification-wise, if we see 2 types, NLPHL and classic Hodgkin lymphoma, NLPHL accounts for around 5% of the cases and the classical for 95%. 4 subtypes, as mentioned in 2016, and luckily no changes in 2022. The subtypes of Hodgkin lymphoma are diagnosed on the basis of their histomorphology. Morphologically, we can see in the nodular sclerosis type, there are Hodgkin cells, a lot of fibrosis and inflammatory milieu. In the mixed cellularity, it's mostly inflammatory milieu and few Hodgkin cells, no fibrosis. Lymphocyte depleted, no lymphocytes, more amount of lymphocytes. And in the NLPHL, the classical Hodgkin cells are not there. What we have is LP cells and inflammatory milieu. It comprises for around 11% of lymphomas in the Western world, with the age standardized ratio of around 1. Both genders are almost equally affected, although we see more of male patients in our scenarios. If we see across the world, we can see that there are some regional variation in the incidence, with higher incidence seen in the developed countries and far lower incidence seen in African countries and Southeast Asian countries, and least incidence seen is Western Pacific regions and Southeast Asia. However, the mortality is higher in these developing countries and least in the developed countries. Then there are age-related incidence variations, like we have a peak in the adolescent and a young adult group and a late peak in the elderly population. So it's one of the commonest type of cancer in the adolescent with a bimodal peak. And in US males, you can see a trimodal peak as well. It's a peak seen in the adult population as well. Why this occurs? Because the nodular sclerosis type is more commonly seen in the younger population, and mixed cellularity and nodular sclerosis are more commonly seen equally in the elder population. In the developed countries, it mostly presents as cervical or supraclavicular lymphadenopathy. Other nodes are less commonly involved. Nodular sclerosis is the predominant subtype. In the developing countries, more commonly it's the mixed cellularity type of pattern. There is no bimodal peak, and the incidence kind of peaks in the adolescent group and stays uniformly throughout after that. More commonly, patients present with advanced stages. In immunocompromised patients like those with HIV/AIDS or post as a part of PTLD, the patient present more commonly with extranodal disease, with B symptoms, advanced stage, and bone marrow involvement. Elderly population again present with subdiaphragmatic disease, mixed cellularity subtype, and B symptoms. Pruritus, although not a B symptom, but is seen in around 30% of the cases. And alcohol-induced pain, which is seen around 17% of the cases, is again one of the very commonly associated symptoms with Hodgkin lymphoma. let's go into the pathology and diagnosis of the disease. So if we see into the cellular origin, Hodgkin lymphoma cell, that is the Reed-Sternberg cell, they do not resemble any normal hematopoietic cell type. So there are some antigen or genes which are from B cell, some from T cell, NK, myeloid, and dendritic cells. But there is clonally, we see there is immunoglobulin heavy and light chain rearrangement. So they derive from pre-apoptotic germinal cell B cells. This is important to remember that these are B cell in origin. How are they formed? They are formed by abscission failure in the presence of functional aurora B kinase. That is, somewhere around here, we see that incomplete cytokinase refusion occurs, which leads to formation of Reed-Sternberg cells. This is a very important slide. The Hodgkin cell, they comprise only around 1 to 2% of the tumor burden in the whole histopathology specimen. All the other cells are mostly the surrounding cells or the inflammatory milieu in which they are present. These are in the form of eosinophils, fibrosis, fibroblasts, dendritic cells, Th cells, cytotoxic T lymphocyte, and so on and so forth. And there is a lot of interaction which occurs between the Hodgkin cells and all these cells, which lead to proliferative advantage for the Hodgkin cells and a variable effect on the protection of Hodgkin cell, leading to different effects on the immunity of the host, leading to a kind of an immunosuppressive state in the host. If we see the signaling pathway, this is the predominant pathway mediated by CD30, CD40, and rank ligand, as well as EBV infection, which occurs in almost 40% of the cases. We see that this is the most common pathway which is involving NEMO, IKK, and NF-kappa B. If we see the genes which are commonly involved or mutations which commonly occur, these occur in the form of TNF LAIP3, NF-kappa B, 1A and 1E mutations, and more importantly, REL amplifications. These are seen in almost like 90% of the cases. Other less common mutations are NIC gains, CYLD mutation, and TRAF mutations. This is important to remember that this is commonly associated with chromosome 9p abnormalities and have therapeutic effect, as checkpoint inhibitors are active in these mutations. So we have some mutational profile leading to prognostic effects. So favorable outcome is seen if the genes expressed are B cluster regions like these, and unfavorable outcome if the extracellular matrix cluster gene predominate. Certain IHC markers like CD38 on macrophages, it has been associated with poorer survival and higher risk of relapse, so on. And we see in the previous slide that IL-10 has a more important role in the inflammatory milieu of the cell. And so high IL-10 levels are so associated with advanced stage and worse outcomes. If we go into a diagnosis, one thing to remember that diagnosis is based on biopsy of the involved node and immunohistochemistry. This is a typical phenotype of a classical Hodgkin cell, CD15 positive in most of the cases, CD13 around 70% of the cases, PAX5 is weak, negative for B and T markers, and Iberish is usually recommended and positive. For the NLPHL, we see these are characteristically B cell markers, CD20, 45, 79A, which are positive, then BCL6 and PAX5 are positive. 15 and 30 are negative in most of the cases of NLPHL. Workup as recommended by NCCN includes routine CBC, biochemistry, pregnancy test in the childbearing females, PET scan or a CT scan for staging and fertility counseling. For selected cases, you may go for fertility preservation, pulmonary function test, especially if you are planning ABVD or therapy. Viral markers are recommended. Advent of PET scan and good markers on PET scan, which can delineate bone marrow very clearly. You may not need bone marrow biopsy in all the cases, except when the PET scan is negative for bone marrow involvement or there are unexplained cytopenias. Ejection fraction is important. Doing an echo is important whenever you're planning an anthracycline-based therapy, especially in patients. We do it for all patients above 40 years of age, and MRI of selected sites, although it is recommended, especially for the spinal involvement by the lymphoma. CNS involvement per se in Hodgkin is very rare, seen in less than 1% of the cases. FNAC, which is one of the commoner modalities used for diagnosis, you should remember that this is not the recommended tool for diagnosis. False negative rate can occur to the tune of 15 to 40%. It's not enough for diagnosis, neither for classification. FNA by flow is one of the emerging method which can be used for diagnostic purposes and has shown good specificity and sensitivity as compared to histopathology. We go into staging. Staging is by the classical Ann Arbor staging and some modifications of it. This is based on CT scan. So stage one is when only single lymph node or single extra lymphatic site is there. Stage two, when two or more lymph node sites on the same side of the diaphragm, or one or more lymph node and some local extra lymphatic extension, but same side of diaphragm, that is either below diaphragm or above diaphragm. Stage three, when both sides of the diaphragm are involved, and stage four, when there is diffuse involvement or two or more extra lymphatic organs are involved. If there are B symptoms like unexplained fever, night sweats, or weight loss of more than 10% over 6 months, these are called B symptoms. It's A if these are absent, and B if any of the B symptoms are present. Bulky disease, more than 10 centimeter in the size of the largest node, or a mediastinal mass covering more than 1/3 or more of the intrathoracic diameter. So what we have is early and late stage. So these are certain classification which are used to diagnosis of favorable risk factor for stage 1 and 2 Hodgkin lymphoma. And three systems are used: the German Hodgkin study group, EORTC, the European group, and the NCCN. If you see that the parameters, commonly ESR and B symptom, mediastinal mass, and nodal sites are common to all three. GSHG persists on the extra lymphatic site, EORTC on the age, and NCCN on the bulky disease. Just remember that the nodal sites in all these three classifications are slightly different. So just whenever you're following one classification, follow it throughout. That is important. For the advanced stage, we have what is called as Heisenberg Index or the International Prognostic Score. It comprises of various parameters like for the patient age, sex, age more than 45, male sex, tumor, stage 4, lab-related parameters like hemoglobin less than 10.5, albumin less than 4, leukocytosis more than 15,000, or lymphopenia less than 600 or 800. We can clearly see that whatever chemotherapy regime you use, either ABVD, BCOP, or escalated BCOP, the overall survival and freedom from treatment failure, they decrease as the stage advances. This can be clearly seen in this figure. That on the top we have IPS 0 with almost 95% survival long term, PFS long term, which is decreasing to almost 50% as IPS score increases to 5 or more. This is important that most of the patients today undergo PET scan for the staging purposes. PET scans were introduced in the management of lymphoma in the early 90s and are now used for tailoring of therapy and risk stratification as well, in addition to staging. They are useful for detection of residual nodes after disease, persistent disease, scarring, and ruling out other non-malignant processes. Earlier, we had other classification system for staging on the PET, but now what we have is dual criteria, which are used almost now for more than 2 decades. It's called negative if the uptake in the node is compared to mediastinum and liver. So 1, 2, and 3 are termed negative. Positive when the uptake is slightly higher than the liver and usually above the adjacent background activity. 5 when the uptake is markedly higher than the liver. And X when new areas of uptake occur which are unlikely to be related to lymphoma. This is different from the Ann Arbor staging, in which X used to denote bulky disease. We can clearly see the interim PET or the end of treatment PET, how it is impacting the overall survival. If the interim PET is negative, that the patient is responding well to chemotherapy. In such scenarios, the failure-free survival reaches almost 95%. But if the PET is positive, it decreases to way below around 15%. This is irrespective of the stage. So even if the IPS stage is high and the interim PET is negative, you have an excellent survival. Few stat pearls around this. So stage 4 was defined as uptake more than liver as compared to the large region of the normal liver. Stage 5 when it is more than 3 times the maximum SUV in the liver or new lesions. Whenever you are assessing for the bone marrow, just remember that bone marrow is kind of proliferative in the Hodgkin lymphoma, especially after chemotherapy, as the bone marrow is regenerating when you're doing interim PET or the end of treatment PET. For complete metabolic response, just remember that if the uptake at the site of initial disease is less than the surrounding normal tissue, you consider it as metabolic response only, even if it is occurring in the marrow. And isolated bone marrow changes, they take longer time to resolve. So few changes in the bone marrow might be lighting up even in the end of treatment PET. Last, this is important, that FDG uptakes occurs due to inflammation. This is widely known, and infections. So whenever you are assessing for interim assessment with PET, so just try to do it before you are giving the next cycle of chemotherapy. For the end of treatment PET, around 6-week interval should elapse. And if you have given radiotherapy in which scarring and inflammation are more likely to happen, use the end of treatment PET after around 3 months of therapy. So treatment. Like BALL, Hodgkin lymphoma has been a success story since the introduction of combined modality treatment. And as you can see, the outcomes have been improving since 1960s, 70s, and 1990s. So if we see in the current era, we see that mortality is less common, especially in the early stage Hodgkin lymphoma, up to 5%, up to 10 years. And most of these cases are again not related to disease unless there is a relapse refractory disease. But there is high amount of toxicity because of cardiac or pulmonary toxicity because of chemotherapy or radiotherapy, as well as a risk of second primary malignancy, including therapy-related AML or MDS. These are important because as we see the outcomes approach almost 80-90%, these less common toxicity and when the patient are surviving for a longer duration of time, these long-term toxicity become important concern whenever you're designing chemotherapy protocols or new trials. So let's start. I'll be focusing mainly on the basis of the NCCN guidelines and providing the evidence for the same. So whenever you have a stage 1A or 2A disease, favorable type, that is no B symptoms, less than 3 sites, ESR is low, age is less than 50 for most of the cases, and stage is 1 or 2. So non-bulky disease, you start with ABVD. This is a standard regime for most of all the patients. 2 cycles, do an interim PET. If the interim PET showed dually 1 or 2, what you can do is you have 2 options. Either you continue with 2 cycles, you can continue with chemotherapy alone, ABVD 2 cycles from these 2 trials, or just ABVD 1 trial from the rapid trial, or the combined modality treatment. This is one of the preferred options for early favorable disease, in which you give involved site radiation. After 2 cycles of chemotherapy, only 20 gray of radiation, or you can give 1 more cycle and 30 gray of radiation from these 2 trials. If there is dual 3, you can continue with the combined modality treatment or consider ABVD for 2 cycles or radiotherapy for 30 gray. For dual 4, you can consider ABVD for 2 cycle restage and do a PET adapted therapy. For dual 5, just rebiopsy and confirm the diagnosis and consider it as a refractory disease. For unfavorable disease, the algorithm is slightly easier. Start with ABVD 2 cycles, do an interim PET. Just slight modification here for the combined modality, you give 2 more cycles of ABVD and a 30 gray of radiation. This is important. We will see subsequently that if the PET is negative, you can continue with the omission of bleomycin. You can continue with ABD for 4 more cycles. This is a very important trial, RATH trial, which was published around half a decade ago. If the dual score is 4 to 5, you should consider for escalation of the therapy to a more toxic regime BFCOP for 2 cycles. Then proceed accordingly. If the disease is responding, consider 2 more BFCOP. And if the disease or ISRT after 4 cycles of BFCOP, after 2 cycles of BFCOP, again, if dual 4 or 5, rebiopsy. Let's look at the evidence. So HD are the German trials. HD 10, 11, 14, 16. These were done for favorable, unfavorable disease. For the favorable disease, what we have is the best prognosis achieved with ABVD into 2 or 4 cycles and limited amount of radiotherapy. For the unfavorable group, what we have is ABVD into 4 cycles and 30 gray of radiotherapy, which is giving the best overall and the best PFS survivals. For unfavorable group, ABVD into 4 plus 30 gray, giving PFS around 89 to 90%. But if you escalate to BACOP, it improves to 95%. Remember, these are German trials. And as we understand from our experiences and the published publication of Indian data, we understand that most of the Indian patients are not highly tolerant of BACOP. BACOP is associated with considerable toxicity and neutropenia. So patients in Germany are able to take care of themselves with this BACOP regime, but many patients in India will require more intensive care and monitoring. Then PET-guided trials, they appeared. Rapid trials, this was for this was a non-inferiority trial in stage 1A or 2A disease, in which IFRT was shown to be non-inferior to 3 cycles of the chemotherapy. Again, RATHAL trial, this is very important. This was for all the stages of disease, in which after PET scan, if the PET scan was negative after 2 cycles, the chemotherapy was compared between 2 arms, ABVD 4 arms or AVD into 4 arms, that is omission of bleomycin. What we had is that PFS 3-year was and overall survival was similar in these 2 arms. So you can safely omit bleomycin if PET scan is negative after 2 cycles. If PET is positive, then you can consider for escalation to BACOP for 4 cycles, with leading to acceptable PFS in these patients. So certain treatment pearls with ABVD. So ABVD has 2 parts. Each cycle has 2 parts, part A and part B, given on day 1 and 14. And this complete, both of these constitute 1 cycle. Just remember that if 1A or 2A is given, you have to continue with B on the schedule time as per the chemotherapy cycle. For most of the patient, you can consider inserting a CVAD, a PICC line, or a port, or a Hickman. Other drugs you are giving are vesicants and irritant and can lead to line-side pains. The regime can lead to significant neutropenia in certain group of patient, but we should avoid the use of GCSF early during the cycles because of neutropenia, as GCSF use has been associated with increased incidence of bleomycin-induced lung toxicity. For such patient, monitor with pulmonary function test. RATHAL trial is important because if you are able to omit bleomycin, you can safely consider usage of this chemotherapy regime for prolonged periods. Interim PET should be done around in the last week of cycle, preferably around day 25 to 27, and end of treatment PET after around 6 weeks of ABVD completion, whatever number of cycles you are considering. Regarding BACOP, there is some data to suggest that procarbazine in BACOP can be substituted with dacarbazine, and this does not compromise the event-free survival and has led to reduced gonadotoxicity and neutropenia. In this, dacarbazine is given on day 2 and day 3. Data is available which suggests that efficacy is equal, transfusion requirement decrease, and acute admission to hospital decrease. Nowadays, with the addition of brentuximab, as we will subsequently see, this regime is further modified into omission of bleomycin altogether and addition of brentuximab instead of that. And prednisolone is substituted with dexamethasone. Equivalent survival, more favorable toxicity profile with this BR-ECAD regime. So these are not so novel agents, monoclonal antibodies. So brentuximab is an anti-CD30 monoclonal antibody, which is a drug conjugate, which is bound to the tubule disrupting agent MMAE. So this is internalized into the cell. The agent MMA is released by the lysosomal proteins, bind to the tubulins and leads to cell death. Similarly, what we have are checkpoint inhibitors. So these are immune checkpoints which are expressed in the Hodgkin tumor cells and the inactive T cells, CTLA and PDL, PD1 and PDL2, which are the important markers on the surface of these cells. So what happens if these are expressed, the T cell become inactive and are not able to kill the tumor cells. Checkpoint inhibitor, they block these receptors, PD1 or PDL1 or CTLA, and the T cells become active and leads to tumor cell death. So these agents have been now tried and tested, especially in advanced stage and now more commonly in early disease as well. So we have various trials. Brentuximab with ABD, that is omission of bleomycin. 2 cycles of this cycle if PET is negative, with 4, PET positive with 6 cycles. 3-year PFS, all the more around 94%. Excellent, again. Then we have trials like Nival trial in with nivolumab, which is a checkpoint inhibitor, which is given for 4 cycles with radiotherapy, followed by nivolumab ABVD for 2 cycles or radiotherapy. We have very good overall response rates and PFS of around 900 to around 100% in the early stage group. And the other checkpoint inhibitor, pembrolizumab, when it was given with for 3 cycles followed by AVD, we had PFS almost reaching 100% at 2 years. Just check. This is for stage 1, 2, unfavorable only, and stage 3, 4. This is important. We'll see in subsequent slide as well that this combination of pembrolizumab and AVD is leading to excellent PFS and overall survival rate in almost all the disease stages. What do we do for advanced stages? For stage 3 and 4, start with AVD. First option, very commonly used in our scenarios. If PET is negative, as per the Rathral trial, omit bleomycin and give 4 cycles. If PET is positive, give escalated Vyckoff for 3 cycles. PET negative, after that, give 1 more cycle. Plus minus radiotherapy. If PET is positive, biopsy. For stage 3, 4, you have an option of giving brentuximab and AVD for up to 6 cycles. Use with caution in patients who have elderly and those with neuropathy. For certain patients, younger patients or with higher IPS score, you can use escalated Vyckoff. How do we use it? Give for 2 cycles, do a PET. If PET negative, give 2 more cycles. You can de-escalate to AVD also for 4 cycles if PET is negative. If PET is positive, then you can consider for 2 more cycles, continue for total 6 cycles. So evidence, Rathal trial we had already discussed. HT14 was the trial which used Vyckoff in the fashion which we described earlier. What we have is 5-year PFS of around 90%, which is excellent. Overall, survival is also to the tune of 95 to 100%. So in various treatment arms, we can see that Vyckoff is leading to 5-year PFS around 90% if given for 6 cycles, then PET positivity 92%, 88% even in the PET positive group. An important slide, how to decide on the radiation intensity. As the chemotherapy intensity increases in the escalated Vyckoff or decreases down to Stanford 4, 5, and somewhere ABVD lies in between. So the need for radiotherapy for almost advanced stages, this decreases, it increases subsequently. For Vyckoff, you require radiotherapy in almost like 10% of the cases, for ABVD in around 40 to 50% of the cases. Well, let's see about brentuximab upfront data. This is important trial, Echelon 1, phase 3 trial, AVD versus ABVD. Median PFS, as you can see, was better in the brentuximab arm, 82% versus 72%. It comes at an increased cost of neuropathy, febrile neutropenia, and grade 3 infection, but less pulmonary toxicity because of omission of bleomycin. Savior is GCSF in such scenario because you are not using bleomycin. It reduces grade 3 neutropenia and febrile neutropenia incidence considerably. So this regime BV plus ABVD can easily be used in advanced stage Hodgkin lymphoma with liberal use of GCSF if required. Neuropathy which occurs is problematic but usually resolved by the end of the treatment or within 1 year of treatment. Checkpoint inhibitors, we have already seen these 2 trials, Nivo plus AVD and pembrolizumab plus AVD. So the CRR and complete response rate and the PFS were almost to the tune of 80 to 100% at the end of 2 years. Let's see about relapse and refractory disease. So important, you need to prove any suspicion of relapse with a biopsy, unless the node is totally inaccessible to you. that is the internal nose, which are usually diagnosed on PET scan and not easily accessible at times. So otherwise, try for the biopsy always for to prove the refractory disease. There are transformation incidences reported in Hodgkin lymphoma as well. First line to go is second line systemic therapy. Give for 2 cycles, restage. If it is responding, consider for high dose chemotherapy, that is autologous transplant. Or for certain cases, if the transplant is contraindicated, you can observe with RT. For such high-risk cases, you can consider for brentuximab maintenance or observation. If the disease is showing partial response, that is doable 4, you can still consider for a transplant plus minus RT and brentuximab maintenance. For dual 5, that is non-responsive disease or new lesions, transplant is not indicated. For such patient, you can give RT or further systemic therapy. If the disease response, consider for allogeneic transplant in such cases. What is the evidence? So we have various regimes like DHAP, ICE plus GVT, ESHAP. All of these regimes are leading to pre-transplant overall response rate of the tune of around 60 to 80% and 3-year PFS of around 50 to 80% in these cases, like 3-year PFS around 70% with DHAP, 70% with ICE and GVD. Overall survivals are good. So novel agents are used in these as well. What we have is when brentuximab is used with ICE sequentially, the CMR or the molecular response PET negativity rates improved to almost 80% and 2-year PFS was improving to around 80%. Last, we see that with the brentuximab and checkpoint inhibitor combination, we have very good PET negativity rates, almost to the tune of 70% to almost 90%, and 2-year PFS reaching 80% in most of the cases. So these are important trials which show that brentuximab, when combined with various chemotherapy regimes, including ICE, ESHAP, bendamustine, DAP, they are leading to excellent pre-transplant PET negativity rates and better 2-year PFS rates. What happens if the disease is refractory to both brentuximab and these? In such a scenario, chemotherapy is usually not very effective. Other agents like everolimus, lenalidomide, and ibrutinib, they are used but not to a great effect. And this is a new monoclonal antibody which came in the town, CD25 and antibody drug conjugate. Again, works on the DNA and leads to cell death. It also improves has a targeting of CD25 positive Tregs, which increase and promote the immunological tumor eradications. What we had is excellent overall response rate around 80% with 50% CR rates. Transplant autologous in CR2 or more. Conditioning is beam, most commonly used. Other also have been used like CVV, TEAM, or BendaEAM. Worst prognosis, the prognostic markers are primarily resistant disease or disease which relapses within 12 months with B symptoms or external disease or those with anemia. Emerging markers like circulating tumor DNA or metabolic tumor volume 1 PET are also there. Important to see that if there is metabolic CR, the PFS rates are around 70%. But if there is PR or active residual disease, this PFS decreases only around 30%. And with time, we can see that the response rates with the autologous transplants are improving. Earlier, it was for the tune of around 50%, which improved around 80% with these two regimes like ICE or Benda-ICE, followed by autologous transplant. And with the Pembro GVD and followed by autologous transplant, the PFS at 2 years reaching around 95%, which are kind of best responses which you can get in a relapse disease. So, more patients are now eligible with the use of Benda and checkpoint inhibitor-based therapies. Post-transplant maintenance, this was initially came with the use of brentuximab when it was used as a 3-weekly regime for 16 weeks in patients who are high risk, that is primary refractory, remission less than 12 months or external involvement. And PFS was of the tune of 60% in the Benda arm versus 40% in the placebo arm. These patients were there who were brentuximab naive. So they had not received chemotherapy-based protocols when as second-line therapy. The benefit of brentuximab maintenance in Patient who are already brentuximab exposed is not very clear, although now commonly used. Other options is which are emerging is the use of checkpoint inhibitor in maintenance. We can see when nivolumab is added to brentuximab, PFS is around 95%. And when pembrolizumab is given after transplant, 18-month PFS is around 80%, which are pretty good rates. Allo, rarely done, but yes, still some indication, medically fit patients with relapsed refractory disease who are requiring multiple lines of chemotherapy to achieve response, or they are relapsing after autologous transplant. Both RIC and myeloablative conditioning are used. Various data which suggest that overall survival at 2 to 4 years of the tune of around 60%. There is some points to consider when you're using checkpoint inhibitors around the time of allogenic transplant. It is recommended that checkpoint inhibitors be deferred, the transplant be deferred for around 80 days after the last use of checkpoint inhibitors, and the use of post-transplant cyclophosphamide, preferably in the haplos, or nowadays more commonly in the match-related transplant, that can mitigate the CPI effect, that is side effect which occur post-transplant in such patients, GVHD and pneumonitis. Special scenarios, elderly. We expect the elderly population to have poorer disease outcomes. More commonly, already I've told you this, medical comorbidities are more common. So what we have is that patient with either early stage, advanced stage, multiple prognostic factors, all these conditions, any of the scenario you consider elderly population tend to have a poorer overall survival and poorer tolerance to chemotherapy. But should we use less toxic therapy? Preferably yes, but their efficacy is not known. Frailties should always be assessed in elderly patient. Not all elderly patients are same. So depending on the frailty index or whatever comorbidity index you use, you can choose your patient for appropriate intensity of regime. We can see the incidence of second malignancy is higher in the elderly, and the 5-year overall survival is almost 2/3 of that seen in the patients who are less than 60 years of age. What is recommended is for stage 1 and 2 febrile disease, you can consider omission of bleomycin, consider some radiotherapy, or even CHOP regime has been used with limited data available. For unfavourable disease, you can again ABVD followed by AVD, or brentuximab based therapy followed by AVD and brentuximab, or brentuximab alone, or brentuximab in combination with dacarbazine in some of these cases. So novel agent, we see brentuximab monotherapy, brentuximab bendamustine, dacarbazine combination, and even checkpoint inhibitors have been used with good success and improving PFS. I should say the overall response rate reaching around 90 to 100% in certain cases, and PFS is not reached, especially with the use of combination drugs, checkpoint inhibitor and brentuximab. For young teenagers and for younger population and younger adult, the outcomes are not as good as the pediatric regime. The regimes include steroids, they have high dose intensity initially, lower dose of anthracyclines, and increased exposure of vinca alkaloids are there, and greater reliance is there on combined modality treatment. So late toxicity, including fertility, second cancer, and organ toxicity, even bone toxicity because of steroid use, they come into a part in such patients and should be counseled regarding these. Sometimes Hodgkin's happens in pregnancy. So mother's health is always a priority in such scenarios. Fetal and maternal outcomes have been pretty fair following Hodgkin lymphoma treatment in pregnancy, nevertheless. And obviously, you should not be using a CT scan or a PET scan for staging. Use MRI and ultrasound for those purposes. Consensus is to delay therapy if possible postpartum, which is usually not the case, more often than not. The risk of chemotherapy is highest in the first trimester, so if possible, delayed to second trimester. ABVD is your regime of choice. Single agent vinblastine has been used, and for obvious reasons, radiotherapy is to be delayed till after delivery. NLPHL, yes, 5% of the cases. This is an indolent disease, usually not very aggressive, but presents with advanced stages in most of the patients. Prognostic features include disease burden and local and systemic symptoms. Sometimes rate of progression can be quicker in certain patients, especially if they have abdominal lymphadenopathy and liver spleen involvement, male sex, and lower serum albumin. Fan et al. They described these six immunoarchitectural pattern. Of these, A and B are associated with better prognosis than the last four. And the last four are called variant histology. These are present in around 25% of the cases and leads to almost threefold risk of relapse. With the pattern A and B, it's around 7% and it reaches around 19-20% with variant histology. How do we treat? For stage 1A and 2A, this is very good results have been shown with only involved site radiation therapy or even observation. Rituximab has been used in certain cases, but has been associated with increased risk of the PFS is not that great. For stage B or 2B, chemotherapy with rituximab is used. For stage 3, commonly chemotherapy with rituximab and involved site radiation is used. If the disease relapses, you can use rituximab in combination with any of the second-line chemotherapy regime used for the classical Hodgkin lymphoma. How do you follow up? So up to 5 years, history and examination, annual influenza vaccine, lab studies, especially TSH, CBC platelet and ESR for relapse and chemistry profile. After 5 years, that's when the long-term side effects come into being. In such a scenario, you should consider for cardiovascular risk assessment, a stress test or an echo at 10-yearly intervals. Lab studies including TSH annually, FRT2 neck, biannual lipids, annual fasting glucose, surveillance for other cancers as required. Usually imaging is, prophylactic imaging testing is not required. PET scan is used only if the previous PET showed a dual 4 or 5. Surveillance PET is not routinely indicated due to high risk of false positive. This is emerging technique, cell-free DNA, that is the DNA component, circulating DNA component excreted by the tumor cells. These have been used for Hodgkin genotype and MRD monitoring. Sample uses commonly peripheral blood, which can be freezed for a longest duration of time. And application are in that for Hodgkin lymphoma genotyping, MRD monitoring, and therapeutic molecular response monitoring as a complement to PET scan that is shown to have additional benefit. Methods are clonosec, that is high throughput reinvent sequencing, next generation sequencing, and digital droplet PCR. Last few slides. So fertility is an important issue. These need to be discussed at the time of diagnosis and planning of therapy. There are certain elements which have been shown to have reduced likelihood of fertility preservation counseling. Primary method of preserving fertility in females is embryo freezing, egg freezing, oophorex, and gonadal shielding, not very commonly available in India. Just remember that ABVD is less gonadotoxic than PACOP. For male, cryopreservation of semen prior to chemotherapy is recommended. It has been seen that ABVD leads to oligospermia in around 12% of the patient versus almost 90% of the patient who receive PACOP. Lastly, about advanced stage Hodgkin's. So, secondary malignancies, that is AML, MDS, is seen around 1% of the cases if you're doing proper early escalation to PACOP, followed by transplant in around 10% of the cases who relapse. But if you're giving ABVD and almost a third of the cases relapse, these will require transplant and AML incidence increases almost 5 to 10%. So, to summarize, in the TB endemic lymphoma, suspicion of Hodgkin lymphoma and persistent lymphadenopathy is important. Diagnosis is by biopsy. Proper staging is required, preferably by a PET scan or at least a CT scan. ABVD remains standard for most of our patients, plus minus local RT, depending on the trial which you are using for your practice. The relapsed patient now have improving outcomes, especially with the use of newer agents, brentuximab and checkpoint inhibitors now being available in Indian markets. Novel agents, first using the relapsed refractory setting, now are cruising to the front line. Transplant for some patients, CR2 or CR3 even, emerging debates. And with very good outcomes, we expect long-term toxicity which need addressing. Now, I'll start with the quiz. What I request you is you can write your answers in the chat boxes. So, question 1. A 9-year-old male presented to OPD with enlarged bilateral cervical nodes and fever. He is not responding to antibiotic course. You are suspicion he is having some lymphoma. What will you do? FNAC of the node and ATD trial, biopsy of the node, biopsy plus IC of the node. So I can see that most of you have written biopsy with IC, which is the correct answer. I've already highlighted that FNAC alone is insufficient. So biopsy plus IHC of the node is something which is recommended for these patients. Let's go to question 2. So this is again a Hodgkin lymphoma patient, 23-year-old male. He is diagnosed as Hodgkin lymphoma and underwent PET for staging. So besides his above nodes, an area in the left lung was reported as X. What does this X means? Bulky disease, external disease, new area of uptake, unlikely related to lymphoma, or old area of fibrosis? You may write your answer in the chat box. Okay, so many of you are writing external disease. On the PET scan, as I had highlighted earlier during the presentation, on the PET scan, X stands for new areas of uptake which are unlikely to be related to lymphoma. So the correct option is C in this case. Okay, let's move to question 3. So this is about a 29-year-old boy, cervical nodes and fever, stage 2B Hodgkin, 2 year back, he had received these therapy. What would be the ideal plan of treatment when he relapses? Okay, so he is presented with recurrence of nodes. Earlier, he had received ABVD 4 and radiation. So what could be the ideal plan of treatment for him at the time of relapse? Be it ABVD 6 cycles, autologous, ICE-DAP 3 cycles, autologous, brentuximab maintenance, brentuximab ICE or brentuximab Benda, followed by autologo and maintenance, or escalated BCOD and OLIVE. Very few people have answered this. So answer could be B or C both. If you have availability of brentuximab, you have a higher percentage chances of this patient going into a PET negative disease before the transplant. In such a scenario, option C would be preferable. But the outcome with ICE or DAP kind of therapy leading to PET negativity is not that bad and is one of the commoner therapies practiced in most of the government centers in India. So B, if the resource constraint, C, if brentuximab is available. Okay, question 4. So elderly female, 69-year-old with cervical nodes and weight loss, 3B disease planned for chemotherapy. What would be the ideal regime for her? ABVD into 6, brentuximab nivo, escalated BCOD, or brentuximab AVD into 4. We have a couple of responses only. So you don't want to give ABVD 6 cycles upfront in elderly patients at this age with high risk of pulmonary toxicity. Anyways, 6 cycles at the outset would be detrimental for most of the cases. Brentuximab with nivo, yes, it has been studied, but in the absence of randomized data, it is not the recommended study. BCOP or BCOD accelerated high amount of toxicity, not recommended for most of the patients. So perhaps with stage 3 study and Echelon trial, I'll like to go with brentuximab with ABVD into 4 for this patient. So option B would be more ideal therapy for this patient. Which of the following is not a long-term concern in patients who have received chemo and radiation for Hodgkin lymphoma? Cardiac toxicity, thyroid abnormalities, myeloid malignancy, and renal failure, chronic renal failure. So all of you are writing as renal failure, which is the correct answer. Cardiac toxicity and myeloid malignancies can be seen because of anthracycline use or etoposide use, thyroid abnormalities because of radiation use. Renal failure has not been characteristically described as a chronic complication. I think with this, I like to conclude and thank you.